15 to 19, new infections again have fallen since 2010, but only by 44%. And in this case, there are really some very marked regional variations. You can see actually, adolescents. You can see that in some parts of the world, actually there have been increases in the number of adolescent infections proportionate to where we started off. So overall, if one were to look at the different areas where we like to think about tracking our progress, where we are and where we want to be are quite different, and there are large gaps across the board for children and adolescents. We need a 73% reduction in new infections in children, an 82% reduction in new infections in adolescents, and significant reductions in deaths in both of these populations if we're to meet our 2030 goals. In any public health program, it's always hard to go that last mile where the initial exponential decline starts to flatline. But in our case, it's become especially challenging in the last few months. And it's because of the sudden and drastic loss of funding, but it's not just less money for HIV. It's also a shift in the political winds away from global health programming. It's a loss of all the supportive systems and structures that USG implementing partners have had in place for so many years to support our work. And critically, it's also a loss in the number of community organizations that have been there at the front line and the ways in which they have been providing vital support to the HIV response globally. And speaking from the UN's perspective, I think it's also worth noting that the lack of the kinds of partnerships that we were dependent upon is also affecting our ability to coordinate and track the response that we have to do more effectively. So across the board, we're really seeing an impact of this change in how we do business and how we might get to our goals. Now, UNICEF and UNAIDS together wanted to try to understand this a little bit better, and so we set about a modeling exercise that used the existing tools of the spectrum data and the goals model to examine various scenarios that might impact the coverage of services. So the modeling looks out to a 2040 horizon. And we basically modeled out 3 different types of scenarios. The blue line is the model where we would have magical amounts of funding that is enabling us to reach our targets and achieve the goals. The darker blue in the middle is what happens if things stay where we are at the moment, and we see no further shifts in the program to close those gaps that I pointed out earlier. And the red line is what would happen if we were to drop the levels of coverage by 50% from where they are now to where they will be in 2030. And that worst case scenario predicts that by 2040, there will be 3 million children that would have acquired HIV and 1.8 million that would have died of AIDS. Now, this is a model of what could happen and not a prophecy of what will happen. So I encourage you to take a look at this document. It's available online. We were hoping to get some copies printed to hand out today, but unfortunately we didn't quite manage to get them from the printer. But I will share a link with you later and you can look at this analysis. It's quite simple to understand and quite sobering in terms of its impact. So can we get back on track? I fundamentally believe that we can, and I think we can do it if we focus on using data to target our investments and thinking about really what works in order to drive action forwards. And I don't want to spend too long on this, but certainly prevention is worth a great deal more than we've previously thought. We've had new analyses that show that a return on investment of about $6.44 for every dollar spent on prevention. So we have to focus on prevention. I think the triple elimination agenda is very important because it's galvanizing momentum, political will from different corners of the health landscape. We now have the STI and SRH people saying, yes, we want to achieve elimination of syphilis. We have the hepatitis community saying, yes, we want to achieve elimination of Hep B transmission to newborns. And I think we can use that momentum to galvanize action for HIV as well and to close those last mile gaps and achieve the reductions in vertical transmission that we want to achieve. We have to focus on adolescents and young mums, and we have to think about incident infection. The bar graphs on the left are the stack bar analyses that UNAIDS produces, and this is the latest one for 2024. And it still shows that in yellow, a large number of new infections in children are occurring because of incident HIV infection in mothers during pregnancy and during breastfeeding. So strategies like using PrEP and lenacapavir, for example, in pregnant women are absolutely the kinds of things we should be investing in to close those gaps. And the graph on the right shows you what the 395s look like for children versus for adults. And it makes the point that really the main problem is that first 95. You're already failing to identify a large number of children living with HIV. You're never going to achieve high rates of coverage and high rates of viral suppression if your first 95 column is so low. So I think strategically, we need to focus our attention on improving case finding in children if we want to make progress. And now a very complicated slide that has a simple message. This is data from UNAIDS and UNICEF that we've pulled together. And what it shows you is where we are on track for different maternal child health indicators, from maternal ART to ANC coverage to attended delivery in health facilities, infant diagnosis, etc. So these are both HIV and maternal child health indicators. And the take-home message here is that often when you see red, it's red across the board. And when you see green, it's green across the board. So there are real opportunities here to link the work that we are doing in HIV with improving other maternal child health indicators. These problems overlap. There are multiple deficiencies that communities and families face that is preventing access across the board to a range of health interventions. So let me close with this last slide and some take-home messages as we get into the discussion around the debate. We have the largest burden of HIV on the continent, but we've also made the most progress and have the most to lose. New infections are declining, but we have a long way to go before we reach the end of AIDS goals. And all of these deaths are preventable among both children and adolescents. So we have to intensify our efforts. The challenge is, how can we do that? And it happens by shifting our accountability, taking African ownership, taking back African health sovereignty, and saying we can identify solutions ourselves. And I would also posit by integrating our work so that we improve child health and maternal health for all, not just for women and children living with HIV. And so I'm going to hand over now to Aisha, who is going to lead us in the debate around whether we should integrate or not. Aisha, over to you.
Let me help you. Thanks, Shaffiq, for making my work so easy. So you've already mentioned why we need to integrate. So if we have to mention that, we need to integrate. So Shaffiq. So by way of introduction, I just want to read this to us, that this house believe. By way of introduction, my name is Aisha Dadi. I'm the Pediatric Breakthrough Partnership Country Lead for Nigeria, and I work for the Society for Family Health. I'm going to be speaking for the motion why we need to integrate. This house believes that ending HIV and AIDS in children requires collaborative models that integrate services and empower communities, such as the Breakthrough Partnership, particularly given changes in this current external environment. Do we think that integration of HIV services matters at all? This question goes to all of us, and we already have the answer with us. Yeah, you will agree with me that when HIV is integrated, we reduce vertical donor dependency and the silos intervention that currently exist in most of the countries. And this intervention, if not integrated in the primary health centers, will continue to remain in silos. And we all know what has happened with the current funding cut. Comprehensive care are strengthened with patient-centered care when services are integrated. You all agree with me with that. And we also know that stigma will be reduced significantly and access will be enhanced when services are integrated. There will be efficiency and sustainability will be enhanced when we integrate. And do we think that government ownership is key in integrating services? Yes. When we align with the national HIV responses, this will improve integration like what happens with the Pediatric Breakthrough Partnership and also the Global Alliance to End HIV among children by 2030. Local capacities will be built at various levels, at the district level or at the local government level. Even in the community, we have capacity built that will sustain integration. Sustainability will also be achieved when this happens. There will be accountability and monitoring of impact will be enhanced when we integrate our programs across various disease burden, instead of the current silos program or vertical program that is operational in most countries. There are proven track record, especially for the Pediatric Breakthrough Partnership that has happened across the 5 or the 4 countries that we have implemented in the past 5 years. The Uganda, we know that when the chaos started early this year, and we understand what happened, and the Pediatric Breakthrough Partnership took that initiative to make sure that communities were trained. And when these challenges started, the government decided to use that in the first place to begin distribution of drugs and all that needed to be done. So if that was not done in the initial time, the integration program will have suffered a great setback. So we can also use the example of the integration in Nigeria, where we are also using the National Data Reporting System to inform program gaps. Now in Nigeria, government have also taken ownership in ensuring that we use data to inform gaps, and that is currently happening in Nigeria, and that is a plus for the government. And for those of us who were here earlier, you also saw that the Namibia success story, that integration of HIV, syphilis, and hepatitis also brought a significant impact in that country. Nigeria also uses the integration program, as I've said earlier, the NDAS program, to triangulate country data that has informed programming. Do we think that clinic community collaboration can improve integration? The answer is yes. We know that network of caregivers can be harnessed for improved retention and adherence. Stronger collaboration between implementing partners and governments can enhance greater linkages. Clinic community linkages improve proximity to caregivers network, and support linkage will increase demand creation and address stigma. Now, what are the proven track record of integration? We've mentioned the Uganda system, we've mentioned the Nigeria, we also mentioned that of Namibia. Now, what are the ways to sustainability? We understand that this sustainability will be key in ensuring that all that we need to do is to ensure that governments at various levels key into this sustainability plan. And once the government is in charge and governments are, bringing all other disease areas and collaborating, we know that the gap will be closed and the status quo that we have currently with the current funding cut will be enhanced. Now, in conclusion, I want to say that let us remove fear, because some people think that once you want to integrate, the gains may be lost. The gains will not be lost. We have reduced stigma. We have more sustainable way of doing things, not the way we were doing before. And we all understood what happened even during COVID, and also initially that you have to start with priority. So change is inevitable, and once we think of integration, we know that we're going to reduce stigma by ensuring that we integrate. And once we integrate, it will bring inclusion, it will reduce stigma, it will ensure sustainability, it will reduce costs and improve treatment and health outcome of the general population, and especially the children that we are all here for. Thank you for your attention.
I am the head of programs at PATA, and I am arguing against the motion. Now, that's a pretty tough job, especially given the recommendations that Shaffiq has given us, but I'll try my best. And if my arguments don't make sense, please just go with the flow. So just thinking about what Aisha has shared with us, I would like to congratulate her for presenting a really good case for integration. But I have some issues in terms of how this is all generalized. We know what the epidemic looks like. We know what the countries have and don't have. And if we start to generalize to say, let's integrate now without understanding the reality and the context of some of the settings we work in, then we're really setting up ourselves for failure. So this image you're seeing here is part of the work that PATA conducted a couple of years ago, just to understand the realities on the ground, because that's what we do. We don't just implement sitting in our offices. We want to hear from health providers what their realities are. And what health providers told us is they're overstretched, they're under-resourced, they work without supply chain management is an issue. So already, and this was before the stop work order, and now throw in the stop work order, we can imagine what our healthcare providers on the front line are trying to deal with. So my first argument, counter-argument against you, Aisha, is that integration adds pressure to systems already struggling, and we need to think very carefully about how much this must cost us if we just go all full-on integration. Okay, the second point, okay, let's just assume integration works, all things equal, and we can integrate according to Aisha's recommendations. you have to stop and think, what does integration mean? I mean, you're not going to go into a health facility and start integrating just like that. Integration starts at the highest level. It starts at national level, at provincial level, district level, and then cascading all of that to the front line. It requires aligning with the government. Yes, I agree with you, Aisha. It requires planning. It requires, think about the guidelines. At the moment, we've got siloed guidelines. And now if we're gonna try and integrate all of those guidelines, how long is that going to take? Think about the training of frontline healthcare providers once we've integrated those guidelines. And then think about, responsibilities. Who's going to be responsible for what? We've had a perfect partnership in the Breakthrough Partnership. I don't want to take that away, that the partners were very carefully selected. But even that, initially, I don't know if I should be saying this, initially it took a while, but not that long, obviously, to just find our spaces and integrate. And I know that I would like to, recommend V for that opportunity, because we've had a great partnership. We've got lessons, huge amount of lessons to share in terms of how to do it correctly. So we did the lesson learning, and now we know what needs to be done and what doesn't need to be done. But all to say, if we're going to integrate, I think we know that HIV services depend on delivery, and if we start rearranging the deck and rewriting things, again, we're not going to be where we need to be in terms of ending AIDS. And then my third argument for you, Aisha, is I want to remind you what's at stake if we're gonna integrate. So again, like I said, let's assume yes, we can go ahead and integrate, but let's stop and think about some of the things that have made HIV service delivery and us working towards our targets a success. It's because we've got specialist skills and within the healthcare profession and within service delivery. We have ART initiation specialists, we've got advanced HIV disease, key populations programming, PrEP and PrEP. Think about when you now then throw that into facilities and expect them to integrate. How is a frontline healthcare provider in a facility, how are they going to be able to take and run with that? We no longer have the support that we've had with partners, because some of the lessons with integration, some of the great lessons are because we've been supported by partners. And now with US government being withdrawn, how do we support our facilities so that they can integrate with integrity, to use the word. And so all to say for this argument is that if we integrate, we are diluting the quality for some of these specialized tasks, and we really face a big challenge in terms of risk of backsliding in the gains that we've made thus far. And then coming on to community engagement, which is one of my favorite topics. I think community engagement, I mean, everyone agrees. And that is the one thing me and my opponent agree on in terms of the value of community engagement. And I agree it's a non-negotiable. However, the point I want to make for you, Aisha, is what you fail to acknowledge is what's going on around us today. I don't know where you've been since January when health system have been falling apart, and communities. Right now, we're hearing about countries reprioritizing and looking about how they work with the little funds that we have. And the one thing that's falling off the table, we know, are communities. And we can't do the work that we do without communities. So think very carefully when you talk about moving on with integration. And for us, and I can speak to our Breakthrough Partnership as well, I think one of our strengths as a partnership was that communities were equal partners at the table. They were meaningfully engaged, not just as implementers, but as equal partners. So I think that we, moving ahead without communities, we're setting ourselves for failure. So my message here is when models like the Breakthrough Partnership are integrated into the government systems, power dynamics change, shift, because communities don't come with money, and communities are no longer an equal partner, and they no longer have a voice. And for us, that's absolutely critical. And then sustainability. You also use some really lovely words, textbook words around sustainability, which to me sounds like, you know, an ideal that doesn't exist, like a utopia. Many countries, if we look at how our governments are struggling right now, many countries do not have the fiscal resources to sustain integration. Even if let's say they're able to integrate today, how is that going to be sustained? Again, you know, the sustained efforts with integration that we've had, I would just like to point out that they have been because we've had partner support. So think again when you think that we can just sustain services. Also, integration is sometimes presented as a cost-saving measure. It's not. It's expensive. It needs resources. So we need to be very careful when we think if we integrate, we're going to save resources and we're going to have more resources for other things. So think very carefully about that, because without real financing and long-term commitment from governments, integration will not deliver what we think it should. So instead, it risks weakening services as some of the funding is removed. So that is, yeah, so to move to my last point now, just to conclude, Aisha, I have a few things for you to take away as you go away thinking about integrating. Integrated collaborative models like the Breakthrough Partnership, they add value. There is no question or doubt about that. But integration alone is not enough. We need to think about what is that going to mean to integrate either service delivery or to integrate models. Sustainability. Yes, a word that's always used, and we all use them when we write proposals because we think it gets us the money. Sustainability requires more than aligning services. It requires, it needs continued investment and political will from governments and community leadership being at the center. So that's another lesson that you need to think about, Aisha. And then my last point is that we heard from Shaffiq, our keynote speaker, about that progress is possible, but only if we focus on our efforts on doing what works, on looking at data, and on investing in integration. So I would like to leave you with that. As you think about integrating, please bear those factors in mind. Thank you.
And Agnes, you have really taken us through the integration, what it will take to really integrate, what we really want to consider so that we maximize the results of integration. We can't just integrate. We have to be intentional. We have to plan, understand what it will take to really integrate successfully. Thank you so much. Great job in this debate. I have the privilege, and let me join my panelists, to be with great panelists, and allow me to introduce them, starting with Ellen. Ellen, welcome to this panel. Ellen is the Executive Director for the Africa Network Adolescent and Youth Person Development. Thank you for joining. I would like also to go to Bahati Haule Thomas, a global health community champion, advocate and public health practitioner in the field of HIV and SRH response. Bahati, thank you for joining us. And next will be Dr. Yewande, who is the Deputy Director in the National Agency for Control of AIDS in Nigeria. Thank you for joining us. Next is Patrice Ndiaye, sorry if I'm not pronouncing it very well, who is the KDAID's Director in Cameroon. And he has 25 years experience in the management of HIV and reproductive health project in the community. Thank you for joining. And Shaffiq is no longer to be introduced. Thank you for joining the panel as well. So let me start with Dr. Yewande. Dr. Yewande, we have listened to all the models that have been described during this session, especially by the wonderful colleagues who have led the debate. So which aspect of the breakthrough partnership model you found most promising and innovative? And with that, thinking of where you sit in Nigeria, what potential challenges you would see in scaling up those modules at national level? And I'm asking this question, taking into account the current constrained resources. So tell us, Doctor.
Thank you very much for the question. So I understand the fears of integration, and then of course the fact that we do need. I think one of the things that came out from the breakthrough partnership is the fact that we've literally moved away from the conversation of just identifying pediatric cases, case finding, which was more or less the conversation about 10 years ago. And we're now looking at the complete care across the cascade. So that's something that's kind of like resonating with me, that, wow, we've gone beyond where we started from 10 years ago. And that's a plus, I think. And the other thing is the fact that we've also come to the realization that we can't do it alone. We do need to work with others to get things done, particularly at the community level. So that's something that is quite prominent in the conversation. To your second question is about how do we move forward with this, considering the conversation. What we've had in the different countries where it has played out is kind of like a pilot. And we're having a conversation about how we can scale up and possibly even integrate into this system. One of the things we have to do is to also recognize that, yes, resources is going to be a challenge, but we also need to start thinking out of the box. I think for those of us in the HIV space, we're so cushioned that we don't realize that the grass may actually be greener on the other side than we actually think. And since we've identified the fact that we can work with different entities to get things done, then stepping out of our cocoon would also help us to get things done. And that means we leverage other community structures to help us get things done. Health has factors that determine whether the individual progresses well or not. And there are entities who are focused on different areas, and we need to partner with those entities to actually help us address the pediatric conversation for HIV.
Thank you, Dr. Yewande. That's really helpful. Now, moving to Patrice. Patrice, let me ask you a similar question, but from a different angle. So which aspect of the breakthrough model do you find promising? Same question as what I have asked Dr. Yewande, but from where you are, having been leading those projects, so what are the elements of that model you could adapt and adopt in your project? Summarizing your answer, thank you.
Okay, thank you very much, Martha, for this question. and for opportunity to for giving me the opportunity to share my views. Let me point something we are experiencing within Breakthrough Partnership is this intensified district approach. It's something may sound is known, but the way we are doing it is more deeper. So first of all, is to engage community, not only like as an implementer and as somebody said already, but also like a partner, but within the community to engage other stakeholders, because we don't have only CBOs and NGOs, but in the community we can have too many community leaders that have to be involved. And also integrating this community and health facility work so that we can find a very good continuation of care. And also we realized that it was important to engage also other sectors. Like in Cameroon, if I'm talking about my country, it's important to engage for a multi-sectorial approach at the local level, not only at national level. That's something very different, it's something very new. What we are doing with Breakthrough Partnership, engaging, for example, social affairs, women empowerment, engaging other sector of government at the local level, I mean, or at the district level.
Okay.
And it's very important also to strengthen the coordination, because we have a very big problem with the coordination at the national level, but now we have made it possible to have also coordination at the local level, bringing all these stakeholders together to give a response, a local response on fight against HIV.
Yeah, Patrice, thank you so much. Coordination, because if we are not coordinated, we will be planning for our failure. Now, Bahati, so as a young person, so how can founders and decision makers better listen to and include the voice of youth people when it comes to planning for the future of HIV services? And together with that, if as Bahati, if you were given an opportunity to tell those decision makers and founders, to tell them two things to make HIV services better for adolescent and youth, what would be those two things? Thank you.
Thank you so much, Martha. So you've asked me two questions which are related to one another in a way. So one, in how can funders and decision makers better listen to young people, and of course in the HIV response. I believe there's a lot that can be done, but just to highlight key things that from the work that we've been doing through the Global Alliance in acting as a bridge between communities and our government and decision makers in our countries. I think one key thing is institutionalizing youth participation in countries. So this means involvement and creation of formal spaces where young people can take part in. So whether this be in subcommittees, in technical working groups, in board meetings, and this also goes hand in hand with creation, but also strengthening and implementation of framework and policies that allows young people from not only being involved, but being decision makers in those spaces. And this to come into play means not only building the capacity of these young people, but also investing in ensuring safe and inclusive spaces for young people to take part. And this framework and policies help in addressing issues such as stigma, age of consent, lack of information, which we know are hindrance with the diversity of young people that are there in our community, because we try to address and bring to the attention of funders and decision makers that young people are diverse with regards to ages, their
needs and demands. As such, the strategies that are needed in order to involve them need to cater to this different population and need and context in order to ensure that we leave no one behind. But mostly we need also to look about creating spaces that not only work for young people, but also sustainable. So shifting those dynamics from not only beneficiaries in the space, but also as decision makers and implementing the space. So if I could say two things that need to be done, I think one, we need to invest in youth-friendly service delivery models. We need to sustain the wins that we have had for years, but also create more wins while going to 2030. But also just simplification of everything. So simplification of engagement, simplification of commodities and pathway, simplification of diagnostics and commodities. So the simpler that they can be, whether it means like long-acting intervention, whether it means simple, that missing route and reaching hard to reach young people, so as to make sure we leave no one behind, but also the young people, as they transition into adulthood, they carry these baseline practices into the decision makers and funders as ourselves become leaders in our own spaces.
Thank you so much, Bahati. Being part of all the steps when it comes to planning for the future, and then, you know, friendly services, that's key. I'm quite sure in the room there are a number of people who have listened to you. That's really clear. Now, Enon, so from where you sit, what role can the civil society, including all the networks at national level, at international level, what would be their role in mobilizing funds to support HIV services in children and adolescents?
Yeah, so thank you very much for having me here once again, and I'm happy to see Bahati, just a month ago, and Gabriel and Botswana together. For me, I would say from a civil society perspective, we also have to look at it in the country. Most of the times we just ask civil society to engage in things when there are not structures to drive it. Most countries don't have what we call investment case. When you don't have an investment case that gives you the detail, how much will it cost me to provide care for one patient for 1 year? When you don't have that total cost, then your effort around resourcing is just you trying your luck. Whatever we get, whatever we don't, we don't. So I would recommend civil society pushing government to develop investment case. Then definitely, where we have investment case like Nigeria, my country, it becomes easier for you to pick that tool and engage the necessary government or policymakers, whether there is need for laws to pass so that resources can be enacted, or whether there is the need for them to increase more investment. So advocacy is very quite important. Thirdly, I see the engagement of private sector is more around the bigger guys. When I talk about the bigger guys, the Global Health Initiative, an institution like Global Fund, UNITED, Gavi, and the rest, these are the people you see most times trying to get the likes of VIV, Gates Foundation, or trying to get the likes of Gilead to allocate or to bring in resources to support life-saving initiative for people. But oftentimes you don't really see that synergy between civil society and the private sector. I'm happy to say we are leading the response in Nigeria, the Gender Equality Fund project, which is GSK and VIP with Global Fund, bringing those resources to Y Plus Global. And then we are leading it in Nigeria, awarding it also to about 14 other organizations. If we begin to see civil society interfacing with the private sector, that's what also brings the value that as civil society we can put on the table. What do Global Fund tell the likes of maybe Rockefeller Foundation that they will do with their money and make them to resource them? How can civil society also start seeing ourselves from that shared value partnership so that resources can be mobilized? Then we need to also be firm in social accountability. The problem is not like there is no money, or there is no funds, or there is no resources. Oftentimes the pathway or the channel or the approach at which a civil society we do oftentimes put us away from accessing some of those resources. I give you an example. If you can sit with the government, and government are doing their annual budget, and they give you an opportunity to enact some of your activity or cost into what the general government will give, that's another way of sustaining whatever we are doing. So, but without doing that, and then seeing that in Africa, for instance, we are always heavily hit when we have issues around funding. So you look at apart from Rwanda today, I don't know if we have another country that have reached the 50% benchmark, the Abuja Declaration. My country, we are still below 10%. So if we are deliberate and firm around seeing how do that domestic funding go up, it will also help. I will just leave it there. Thank you.
Thank you, Aaron. Certainly, there is the role you have described. The civil society can play in mobilizing funds. So that's great. So as we wrap up, Shaffiq, you have listened to the voice of youth, the government, the civil society in a sense of project-led at national level. So in 1 minute, what can you tell us about how really we make sure that regardless of the current constrained resources situation where we are now, how can we continue to prioritize HIV services in children and adolescents? In 1 minute.
A tall order. I think really one of the things that I've taken away from this discussion is the incredible ideas that I'm hearing from leaders in ministries of health, doctors at the front line, community representatives, people living with HIV themselves. I feel like a decade ago, we wouldn't have had this kind of dialogue, and maybe this sort of silver lining to the dark cloud is the way in which it really forces us to think, take stock, and realize that help is not coming from anywhere else, but must come from our own solutions and from ourselves. So maybe for me, if there is a takeaway, it is to take this moment as a moment to find our own voices, for leadership in the continent to take back that sovereignty. You know, I think for too long we've abdicated the responsibility for the response to the big donors. And in fact, big donors have also, the money doesn't come as a blank check, right? It comes with strings attached. And it is those strings often that have hampered our ability to come up with our own solutions. I've heard great ideas here. I think we need to workshop them, think about them ourselves internally, and turn them into action that we drive, we control.
Thank you, Shaffiq. Thank you. I'd like to thank the panelists. We have to make sure that youth voice are listened to. We also have heard that if we look at the breakthrough partnership model at project level, at country level, there is an opportunity to adopt and adapt, which is wonderful, and also the community. Thank you so much. Thank you for the effort. So as we are leaving the stage, let us, if the video is ready, is it ready? Let's see how video. Please start to play it. Thank you so much, everyone.
The greatest impact of the funding cut has been an initial closure of HIV services like testing, viral load sample collection, and also closure of youth-friendly activities like kids clubs. And this led to overburdening of the already constrained frontline health workers. There was also the widespread shortages of ARVs, and of course, this led to a lot of interruption in treatment.
There were no longer any staff at the clinics to link moms and children back into care. This included counselors, included community health workers, and also even at household level, we could no longer be able to test as many moms, as many children. We could not identify moms who needed antiretroviral therapy, who needed to be engaged in care.
There's been disruption of some preventive services for HIV, as well as outreach services. A lot of clinics have been closed, which were supported by partners. And we foresee a gap in retention and also in finding children in the community through HIV testing being a problem.
It means it's integrating care where people can access HIV treatment, mental health, and sexual reproductive health services in one place without judgment and without barriers.
It's a shift towards expanding health insurance coverage and making it mandatory that children and adolescent services are explicitly included in the health insurance scheme. We should scale up integration of HIV services with other services, for example, maternal and child healthcare services.
One way is thinking about making sure that financing can support and finance the integration of HIV services at primary healthcare level, at district level, at provincial and referral hospital. The second thing is thinking about national health financing insurance scheme. And we know many of these are being rolled out in Africa.
We need to have a healthcare provider who's equipped with knowledge, commodity to use on our clients so that they are managed properly. In short, we need trainings for healthcare providers.
Every person, each sex worker, each woman, each adolescent, girls and boys, they deserve to be heard, they deserve to be cared.
My hope is that they will live and grow healthy, they will be strong and they'll be confident, and that they will not have interruption in their services, that they will live without the fear of waking up one day and have their medicines interrupted.
I am very hopeful for an AIDS-free generation, and I just hope that we are able to forge together, and we are here as EGPAF, and we are really calling on others as well to just join us and keeping our promises for children, for moms, and for their families.
So we should not give up. We should continue with our campaigns. We should continue with fundraising for funds. And secondly is that isolation and exclusion does not stop the epidemic, but rather it is us to stand up and push on, because we said our goal is to stop AIDS by 2030.
We should have a future where no child is born with HIV. We should have a future where there is universal access to HIV prevention, care and treatment. We should have a future of adolescents who are empowered to take a lead, to live a healthy life and demand for services in an HIV stigma-free environment.